Scott Brown's Rhinology, Chapter 87, Anatomy of the Nose and Paranasal Sinuses. Today we are going to learn about the developmental and functional anatomy of the paranasal sinuses. Developmental and functional anatomy of the paranasal sinuses. The paranasal sinuses are paired structures lined by ciliated, pseudostratified columnar respiratory epithelium identical to that in the lower airway. The cilia beat in a coordinated fashion to carry the mucus blanket which traps particles from the sinus into the nose through a series of well defined pathways. The paranasal sinuses are divided into anterior, posterior, and sphenoid compartments that serve as a functional units based on these drainage pathways. The anterior functional unit is comprised of the maxillary, anterior ethmoid, and frontal sinuses. The sinus drains into the nose through the osteomeatal complex in the middle meatus. The posterior functional unit is comprised of the posterior ethmoid sinus and drains into the nose through the superior meatus. The sphenoid functional unit is comprised of the sphenoid sinus and drains through the sphenoethmoid recess located medial and posterior to the superior turbinate. Although the anterior and posterior ethmoid cavities share a common name, they are completely separated from functional entities with different drainage pathways and embryological origins. The concept of the sinonasal compartment or functional unit has clinical relevance during endoscopic sinus surgery. Once a compartment is entered with surgical instrumentation, all diseased mucosal cells within the compartment must be completely dissected in order to remove obstructive phenomenon. Avoid leaving behind disconnected cells from the surgical cavity, prevent mucosal formation, re establish post surgical mucociliary function that is free of recirculation effects, and enable maximal delivery of topical therapy. The ultimate goal of surgery, whether limited or extensive, is the creation of a new functional sinus cavity. Anterior functional unit. Box 87.13 Uncinate process and maxillary sinus. The uncinate process is a sickle shaped bone which attaches inferiorly to the inferior turbinate and palatine bone and anterosuperiorly to the lacrimal bone. The posterior superior attachment will be discussed later along the frontal sinus. The true maxillary ostial opening is covered by the uncinate process and cannot be viewed endoscopically in a sinus cavity that has not been previously opened surgically. The uncinate, together with a fold of mucosa called the anterior and posterior fontanelle, cover the opening to maxillary sinus. Accessory ostia may be present in the fontanelle that can be mistaken for a true maxillary ostium. Failure to correctly identify the true ostia and connect it with the common sinus cavity may result in a phenomenon known as mucus recirculation. During recirculation, mucus is directed towards the natural opening along the mucociliary drainage pathways and re enters the sinus through the accessory ostium. Ethmoid bulla. The ethmoid bulla is the largest and most consistent anterior ethmoid cell. It attaches to the lamina pepracia laterally and has variable attachments to the skull base and basal lamella, creating a series of clefts and spaces within the middle meatus that are well described but have few little clinical significance. The reader is referred to the consents of document produced by the Anatomic Terminology Group for a detailed description of anatomic terminology and nomenclature. A variety of normal anatomy in this region is called a Haller cell. A variant of normal anatomy in this region is called a Haller cell. A Haller cell is an infraorbital anterior ethmoid cell that pneumatizes into the maxillary sinus and may cause obstruction of the maxillary sinus ostium. Complete removal of the ethmoid bulla is critical to define the medial or orbital wall as landmark. Middle turbinate. The complex shape of the middle turbinate is divided into three segments according to the sagittal, coronal, and axial planes to which it is oriented. The sagittal segments attach to the skull base at the lateral lamella. The coronal segments creates the basal lamella which separates the anterior ethmoid, those cells draining in the middle meatus, and posterior ethmoid draining via the superior meatus cavities. There is no natural connection between these two cavities. This partition is often not smooth due to posterior projections of the anterior ethmoid air cells and anterior projections of the posterior ethmoid air cells. The safe working distance from the skull base established by the maxillary sinus roof or orbital floor is used as a reference point to proceed through the basal lamella and enter the posterior ethmoid cavity. The axial segment the axial segment of the middle turbinate attaches to the lateral nasal wall and is the entry point of a terminal branch of the sphenopalatine artery. Frontal sinus. The vertical portion of the paranasal surgical box defines the anatomical limits of dissection of the frontal recess. The boundaries of the vertical portion of the paranasal surgical box include the intersinus septum and middle turbinate medially, lamina papyracea laterally, and nasofrontal beak anteriorly, and skull base posteriorly. Successful identification of these anatomical limits of the surgical box and removal of all cells within its confines ensures complete dissection of the frontal recess. To define the limits of the vertical portion of the paranasal surgical box, one must consider the various cells that may encroach on this space from anterior, posterior, medial, and lateral directions. Agonasi, posterior superior uncinate process, and frontal ethmoid cells. Anterior structures encroaching on the frontal recess include agonasi, lateral uncinate process, and frontal cells. The agonasa is the anterior-most ethmoid air cell and its medial border is formed by the uncinate process. The degree of pneumatization of the agonasi influences the position of the superior uncinate process and thickness of the bony nasofrontal beak. The uncinate process can insert into the medial orbital wall, skull base, or middle turbinate. Recent studies have demonstrated that the uncinate has multiple attachments in more than 50% of cases rather than a single attachment pattern. Classic teaching that describes the three distinct attachments of the uncinate process, which determines the direction of the frontal sinus drainage pathway, is neither surgically relevant nor accurate. The uncinate process inserts onto the medial wall, orbital wall in 85% of cases. Thus, the frontal recess drainage pathway is medial to the uncinate process in 85% of cases. An uncinate process with an isolated attachment to either the skull base or the middle turbinate without attachment to the medial orbital wall occurs in only about 15% of cases. This attachment pattern leads to the surgical obvious frontal drainage pathway located lateral to the uncinate process that is easily identified at the time of surgery. The surgical rule holds true that the frontal recess is medial to the remnant uncinate process or vertical bar in 85% of cases, with the other uncinate attachments representing easy surgical arrangements. Box 87.14. The process inserts onto the medial orbital wall in 85% of cases, resulting in a frontal recess drainage pathway that is medial to the uncinate. Frontal cells represent cells of the first ethmoid terminal and that pneumatize above the agonasi towards the frontal sinus. According to the Kuhn classification, a type 1 frontal cell is a single frontal ethmoidal cell above the agonasi and below the frontal sinus floor. Type 2 is a tier of cells above the agonasi. Type 3 is agonisi. Type 3 is a cell pneumatizing on into the floor of the frontal sinus, and type 4 is an isolated frontal ethmoid cell within the frontal sinus. Using multiplanar reconstructed imaging, Walmart further modified this classification to more accurately describe type 3 cells as frontal ethmoidal cells that fill less than 50% of the frontal sinus, and type 4 cells as filling greater than 50% of the sinus. These classifications of frontal sinus cells are primarily to ensure that the surgeon's view of a large frontal recess cell lumen will not be mistaken for the true frontal sinus. Identification of these frontal cells on preoperative imaging prevents false assumption of completion sinusotomy. Supraorbital ethmoid and suprabulla cells. Posterior structures encroaching on the frontal recess include supraorbital ethmoid cells, suprabulla cells, and ethmoid bulla. The supraorbital ethmoid cells are anterior ethmoid air cells that extend superiorly and laterally over the orbital roof. These cells are recognized on imaging, giving the appearance of a septated frontal sinus on coronal view and a cell located posterior and lateral to the frontal sinus and axial view. Supraorbital ethmoid cells have three clinical significant features relevant to the frontal recess. One, they can cause obstruction of the frontal recess. Two, they can be falsely mistaken for true frontal sinus, leading to incomplete surgical dissection. Three, they are associated with the low position of the anterior ethmoidal artery within a mesentery because these cells pneumatize downwards from the skull base behind the artery. The supraorbital ethmoid cell also creates a very narrow orbitocranial cleft posteriorly that can be very challenging to operate within. Suprabulla or frontal bulla cells are pneumatized extensions above the ethmoid bulla up the skull base and on the posterior table of the frontal sinus. These cells can become quite large and mistaken for either the skull base or the posterior table of the frontal sinus. Failure to recognize these cells on preoperative imaging will also result in incomplete surgical dissection of the frontal recess. Figure 87.21, anterior structures encroaching on the frontal sinus depicted by a series of onlay diagrams. A is the left frontal recess with all cells intact prior to surgical dissection. B is the left draft 2A frontal sinusotomy with removal of all cells encroaching on the frontal recess. The relative positions of the anterior cells are superimposed, including C is the frontal cells in green, D is the aganesa in blue, and E is the superior uncinate process in yellow. Figure 87.22, schematic diagram of the uncinate process with different arrangements of its superior attachment. A is a classic teaching describes three distinct attachments to the medial orbital wall, middle turbinate, and skull base respectively, which determines the direction of the frontal sinus drainage pathway. This description is not accurate. B is the uncinate process that has multiple attachments in greater than 50% of cases rather than a single attachment. Figure 87.23, posterior structures encroaching on the frontal recess depicted by a series of onlay diagrams. A is the left frontal recess with all cells intact prior to surgical dissection. B is the left draft 2A frontal sinusotomy with removal of all cells encroaching on the frontal recess. The relative positions of the posterior cells are superimposed, including C. Supraorbital ethmoid cells in green, and D. Suprabulla cell in blue, and E is the ethmoid bulla in yellow. Box 87.15. Supraorbital bulla ethmoid cells have significant features relevant to the frontal recess as they can 1. Cause obstruction of the frontal recess. 2. Be falsely mistaken for the true frontal sinus leading to incomplete surgical dissection. And 3. Be associated with the low position of the anterior ethmoid artery within a mesentery, placing this artery at risk of injury during surgery. Suprabular cell pneumatize up the skull base and failure to recognize these cells preoperatively will result in incomplete surgical dissection of the frontal recess. Medial structures encroaching on the frontal recess include intersinus septal cells and medially inserting uncinate process. Intersinus septal cells represent pneumatization of the frontal sinus septum. Lateral encroaching structures include frontal cells, agenesis, and a lateral uncinate process attachment. Posterior functional unit. The posterior functional unit is comprised of the posterior ethmoid air cells with drainage into the superior meatus. A variant of normal anatomy in this region is a lateral and posterior pneumatization of the posterior ethmoid cell called an Onodi cell. Onodi cells pneumatize over the optic nerve, exposing this critical structure to injury during surgery. These cells can also be mistaken for true sphenoid sinus, leading to incomplete surgery. Application of the maxillary sinus roof or orbital floor landmarks identify the level of the sphenoid ostium and enables the complete dissection of the sphenoid sinus. Box 87.16 Onodi cells pneumatize over the optic nerve, placing the optic nerve at risk for injury during surgery. An Onodi cell can be identified on the coronal CT view as giving the appearance of a horizontal septation within the sphenoid sinus. Sphenoid functional unit. The sphenoid functional unit is comprised of the sphenoid sinus, which drains into the sphenoethmoid recess. Identification of the sphenoid sinus enables the surgeon to determine the level of posterior skull base at its lowest position. The sphenoethmoid recess is the space between the superior meatus and septum. The supreme turbinate may be seen here. The sphenoid ostium opens behind the superior turbinate and is neither medial nor lateral to it. Complete removal of the anterior sphenoid wall laterally enables a surgeon to identify the medial orbital wall at its posterior position. The main structures associated with the sphenoid sinus include the optic nerve, carotid artery, and sella turcica, where the pituitary gland is located. The pneumatization pattern of the sphenoid sinus can be variable. The different types include cellular 90%, pre-cellular 9%, and conchal 1% pneumatization patterns. The cellular type describes sphenoid pneumatization posterior to the sella turcica. The pre-cellular type describes sphenoid pneumatization up to the anterior sella, and the conchal type describes a shallow bowl with minimal sphenoid pneumatization and trabecular membrane bone between the sinus and sella. The sphenoid sinuses can also pneumatize laterally into the pterygoid root, resulting in the presence of a lateral sphenoid recess. Conclusion. The paranasal sinuses represent some of the most variable human anatomy. An understanding of the developmental and functional anatomy is critical to understand patterns of disease and pathophysiological events in the sinuses. However, it is an understanding of the anatomical boundaries of the paranasal sinus that are critical for the surgeon to avoid major complications, ensuring that ostia are incorporated into the common surgical cavity provides the basis for a functional post-surgical cavity rather than a discrete identification of their location. Best clinical practice. The paranasal sinuses represent some of the most variable in human anatomy. Although a knowledge of the developmental and functional anatomy is critical to understand patterns of disease and pathophysiological events in the sinuses, they are often of limited assistance during surgery. The anatomical boundaries of the paranasal sinus are critical for the surgeon to avoid major complications. Variable clefts, pneumatization patterns, and features that are easily distorted by pathology and prior surgery are not good guides for the surgeon. Ensuring complete surgical dissection with ostia incorporated into the common surgical cavity provides the basis for creating a new functional neosinus cavity postoperatively. Further research, future research. Understanding the epithelial dysfunction with intrinsic mucosal inflammation, local microbial colonization, and mucociliary dysfunction as the contributing factors in patients with chronic sinus inflammation is evolving. Key points. Identify key fixed anatomical landmarks to delineate the limits of dissection of the paranasal sinus surgical cavity for safe and complete endoscopic sinus surgery. The main structures are the orbit and skull base. These are defined by 1. Maxillary sinus roof, which is the orbital floor, 2. Medial orbital wall, 3. Sphenoid sinus roof, which is skull base, and 4. The lateral sphenoid wall, that is the orbital apex. Paranasal sinuses are divided into anterior, posterior, and sphenoid compartments that serve as functional units based on mucociliary drainage pathways. Once a compartment is surgically entered, all mucosal cells within the compartment must be completely dissected to create a new functional new sinus cavity. Thank you.